So, if you look at the diagnostic algorithm, the most important thing here is the clinical story that we talked about. Physical examination, clinical story together, making the clinical syndrome of heart failure. And once you do that, you do the ECG and the labs. The labs here, the most pertinent would be the renal parameters and the hematological parameters to make sure you're not missing anemia, CKD, hypothyroidism. Once that is done, then you would go to the natriuretic peptide, and we use NT-proBNP because we are using a lot of ARNI in our practice today. So we don't use BNP, we're using NT-proBNP, and the number that is given is 125 or more. And once that is positive, the transthoracic echo becomes then the most important tool to look not only at the ejection fraction, which is central to how we manage these patients, but as was already discussed, the various other causes of heart failure which we will come to. And once that is done and you put this patient in a specific basket of HFrEF or HFpEF, then you would do more advanced techniques and advanced imaging. So all these tests have a certain level, and the BNP 12-lead ECG echo has a very high class 1 level of evidence, including the blood tests. And so these are important parts when you're evaluating a patient with heart failure, and these are now mandatory. The Association of Physicians of India have not been far behind, and they too follow a very similar pattern of history, examination, investigations, and confirmatory. And for those of us who do not use NT-proBNP in the peripherals, then echo becomes a very important tool, and it's a central tool for making the diagnosis and putting that patient into a specific category. And when you look at all the three guidelines, both the American College, the European Society, and the Cardiology Society of India, more or less are in sync with making the diagnosis of heart failure clinically using the NT-proBNP echocardiogram. And then, because in our country ischemic heart disease is so prevalent and such a big driver, a coronary angiogram. So the lab tests we discussed, the central point would be the BNP, a complete blood count for anemia, electrolytes to look at the kidney issues, as well as any complication of therapy, and liver function, especially if there's a right-sided failure or a chronic congestion to the liver, you could make that out. Now the ECG again forms a very important central point of this patient, and four important things that we need to do is look at the QRS duration, look at whether the patient has a left bundle branch block, because that could have a very important prognosis if it is more than 150, and also could help us choose a therapy like a CRTD for these patients who are not responding to medical therapy. Left ventricular hypertrophy and atrial fibrillation, again a very important point where you would like to add a NOAC in these patients going along. Now, as I said before, echocardiography is a very important point. It's the hallmark of heart failure. So the ejection fraction, the dimensions, the valve motion, valvular abnormalities, either primary or secondary. We did mention that rheumatic heart disease also is a very important part of heart failure in the young. And most importantly, when we're looking at a HFpEF patient, the diastolic parameters become very, very important. Now, additional imaging studies like the X-ray, which is the only study which will look at the lung congestion or the lung vasculature, is very important. And it's very important to look at that lung X-ray before you move ahead. I will talk a little detail on the cardiac MR and nuclear techniques. Suffice to say that these techniques follow after the essential investigations are done, and echo gives you a certain direction point as to what this patient is having, ischemic versus non-ischemic. Then you would employ both these techniques to further elucidate what else this patient is having. So primary to the diagnosis of this young person's heart failure is the ejection fraction that we talked about. And as we know, the ejection fractions are different and they have different connotations in terms of prognosis, and also, like we know, in terms of treatment. So while echo is the central point for a heart failure patient's journey, once it is done, it's important to have a gold standard in terms of ejection fraction to make sure that any improvement based on your 4-drug therapy or the Fabulous 4 or any other therapy, whether it's CRT will now be based on something which is the inter-observer variation is low. It's a windowless system of imaging, and you get a very good ejection fraction, volumetry, and also the mass. So this is a good an important gold standard before embarking on specific therapy for heart failure. And MRI is a very good tool, and this sequence can be done in about 10 minutes. It doesn't employ contrast and can be done very quickly and efficiently. And if you look at the recommendations, irrespective of the ejection fraction of these patients from mild, moderate to severe, CMR is the gold standard tool. And whether you've had an ischemic heart disease, MI, LV dysfunction, or if it is a non-ischemic, MRI has a very appropriate use in terms of quantification of LV function as well as volumetry. The second thing that we want to see in heart failure is whether this patient has a coronary artery disease or not. And this has traditionally been done by the angiography. And if you look at Felker's data, you will see that the ischemic subsets always fared worse whenever they were the cause of heart failure. And because of this, traditionally we have been using the coronary angiogram. You can see the normal angiogram on the left, and here there is an LAD occlusion, as a means to ascertain whether this patient who's come with a severe LV dysfunction, global hypokinesia, has an underlying CAD or not. But what we have also discovered over the years is that the cardiac MRI, not only being an important point for volumetry injection fraction, also has a means to tell us what the underlying basis of heart failure is for this patient. And if you look at the orange arrow above, you will see the very typical subendocardial delayed enhancement, which is there both in the inferior septum as well as the basal anterolateral wall, compared to the next patient, which is the mustard arrow. You will see that the scar here is actually mid-myocardial, and there is a space between both aspects of the scar, suggesting that there is no vascular etiology in this patient with heart failure. And the third type of patient is a patient who has what is called a subepicardial kind of scar, especially involving the infralateral wall, and usually seen in younger patients after a typical viral syndrome. And we saw a lot of this during COVID, which is suggestive of myocarditis. So without resorting to an angiogram, by the use of MRI, you can have a fair idea about the underlying cause of the heart failure. And now what we are doing is we are employing what is called a T1 mapping sequence. So single stain, no contrast, you get what is called T1 maps. And based on the disease, the T1 and the ECV, you get a whole host of diseases that can be looked at in heart failure, starting from iron overload patients right up to patients with amyloidosis, myocarditis, infarction, and even the hypertrophic cardiomyopathy group of patients based on their T1 values. And this does not employ using contrast again, can be done in 10 minutes. And then you have a good idea about the diffuse fibrosis which is there in these patients.